King. I'm a consultant radiologist at Southampton. I've been there for, since 2009 when I began my radiology training there, and as a consultant for about 12 or more years. So I've been doing this procedure for quite a long time. But when I tell people I'm a consultant radiologist, they think that I must sit in a dark room and look at X-rays all day, because that's traditionally what radiologists do. And some just still do that. But a lot of us are now moving into different areas, and we're using our skills with imaging, so X-rays, CT and MRI, to do procedures and treat patients. And as Hazel said, that's one of the things that I do. So this is the picture that we took a month or so ago when we did our 1,000th kidney tumor ablation. That means that we've done only about a handful of people around the world will have done a similar number of cases. And this picture really just shows that this is a team event. There's anaesthetists, there's nurses, there's radiographers, and of course the doctors that are involved too. And this picture's taken in a CT scanner. You can probably just see at the back, there are some balloons next to the CT scanner. And that's because we use the CT scanner to do the procedure. And I'm going to show you a bit more about that later. So you might hear us. We're officially consultant radiologists, but this is a specialty called interventional oncology. And in some places, it's even called image-guided surgery, which is, it sounds very American to me, but it gives a sort of understanding that we're actually doing treatments now within radiology. So here's sort of what it looks like. So kidney cryoablation is ideally for small kidney cancers. So these are often the cancers that are found when someone has a scan because they've got gallstones or they've got back pain, and we accidentally find that they've got a small kidney cancer. It should be confined to the kidney, so it hasn't spread to other parts of the body. And if you're up with the staging system, a stage T1A tumor would be a tumor that's 4 centimeters or less in size. We can treat T1B tumors, which go up to 7 centimeters. But we know from the data that the very best results come with the T1A tumors, so those less than 4 centimeters. And in that scenario, you could really expect that about 98% of patients will have one single treatment of cryoablation, and that will be it, done and dusted. So these are some scan pictures, and this is a patient lying on their tummy in the CT scanner. So their back is here, their tummy's at the front, and this is their kidney. And we can see there's a nodule out the back. I've blown that picture up there so you can see the nodule. And that's the little kidney cancer that we were treating. And we do it by passing these needles through the body into the tumor, using the CT to show us where they go. And at the end of them, we can create this ice ball. And that's this dark area that you can see in the kidney. So we can see that the ice ball is big enough to treat and cover the tumor. And then the needles are removed and the tumor is dead inside the body and it dies away. This is one of the earliest cases we did. So probably about 10 years ago, we did this particular case. But we've collected all our evidence, as have other people around the UK and the world. And as Hazel pointed out, it was fantastic that this has now been approved by NICE. Kidney Cancer UK and some others did some great work to get NICE to produce some kidney cancer guidelines this year. And really, for the first time in a major national guidance, they have acknowledged that if a patient simply doesn't like the idea of having a big operation, they could reasonably choose to have ablation instead. And so that means that patients can now go to their urologist, to their surgeon, and say, I'd like to talk about ablation instead of surgery. And they are really duty bound to tell you how that would happen and how to go about finding somebody. So in a nutshell, that's what kidney cryoablation is for and what it's about. Here's a picture of us doing the procedure. So this is the CT scanner, and you can see we're looking at a screen, so we can see what we're doing. And these are the probes coming into the patient. And this white stuff is a bit like snow. It's sort of frost on the probes because we're doing the treatment here and they've got very, very cold. I'm going to play this video, which is of me doing a procedure. It's sped up, so it looks a little bit like a Benny Hill video, but it gives you an idea of how this works. The patient is anaesthetized under the blue drape, and so they're inside the CT scanner, and just on the right here, you can see some of the anesthetic equipment. So we do this under a general anesthetic to keep the kidney still, because trying to hit a moving target is difficult. And these needles are placed, you can see I've popped it in the skin, and now the patient's inside the scanner. And on the right here, you see the screens. I'm doing a little CT scan to see where the kidney's going, where the needle is going. Another scan to check it's in the right path just before it goes into the kidney. And then I can place it into the tumor using the CT to show me that we've put it in the right place. So we put these needles in with a tolerance of about 2 or 3 millimeters. So it's incredibly accurate. And we space them around the tumor to know that they're going to be building an ice ball that's the same shape and size to each particular tumor. So we can be very clear about the treatment that we're delivering. Now, most people will go home the morning after their procedure, but some can even go home the same day. So it's really very well tolerated. It takes about 90 minutes to do under a general anesthetic, and we get very good success rates. Now we're just going to move on. This is a video that is a patient experience video, which kind of explains everything from a patient perspective and a little bit more detail. So excuse me for using something that's already prepared, but I think it's a really useful way of portraying the message. So I'll play this. I hope it's going to play.
Finding out that I had kidney cancer on my birthday was, of course, a bit of a disappointment, but encouraged to find out at the same time there was a very hopeful treatment for it. I'm David Stanley, 75 years old, and I come from Alderney in the British Channel Islands. My wife and I do quite a lot on the island for community activities, putting on shows, entertaining people, that kind of thing. I was fairly fit and healthy until about 2020, when I encountered a gallbladder problem, which led to some surgical difficulties, which lasted for a few years. As a result of which I had a scan. In this scan, they picked up that I had a small growth on my right kidney. I was aware that surgical intervention was a possibility, and indeed I believe in other areas of the country the solution would have been to just remove the kidney. However, given my circumstances and the previous procedures that I'd had, major procedures, with the possibility of another one on the horizon, cryoablation was very much recommended as the most suitable candidate for treating my kidney cancer.
I first met David at the beginning of 2024. He came over for a consultation about kidney cryoablation, but I'd actually known about his case for a month or two, having discussed him in the MDT meeting locally. Like many people, David's kidney cancer was found whilst he was having a test for another problem. He had some issues with his gallbladder and his bowel, and the scans that he was having done at that point found this small kidney cancer in his right kidney.
The outcome of the MDT in Southampton was a recommendation for the cryoablation procedure.
When we think about the treatment options for small kidney cancers such as David's, effectively there are 3 routes that could be followed. For the very smallest tumours, we can consider a period of surveillance where we simply watch and see what the tumours do as to whether they may grow or not. Above a certain size, then we would broadly think between a surgical option or a focal therapy option. In David's case, he'd had quite extensive surgery to his abdomen recently. And fortunately for him, his tumour was at the perfect size for offering treatment with freezing, cryotherapy, and could have been offered surgery, but the previous operations to his abdomen made that much more challenging. We use the CT scanner to guide needles or cryoprobes into the tumour. We can put them very precisely so that they match the shape and the size of the tumour and only destroy the tumour and a small cuff of normal kidney tissue without causing unnecessary collateral damage.
The procedure was just so straightforward. There was nothing to it.
So the cryoprobes that are placed into the tumour have argon gas that passes through them, and the passage of that gas through the needle allows the surrounding tissues to cool down, and we can cool them down sufficiently that an ice ball grows, and we can see that in the CT scanner. The ice is very, very cold at the centre. It's down to about minus 140 degrees Celsius, and at those temperatures the ice can freeze inside the cells, the cancer cells, and rupture them and destroy them. And then we can thaw the tissue to allow the water to move around the cells. And then we freeze the whole thing again to make sure that we get confluent cell death, but also to allow some killing off of the small blood vessels that could supply the tissue, much like you would have seen in something like frostbite.
The recovery itself was very straightforward. I can't remember any discomfort from it. I just recovered ever so quickly. It's opened up the rest of my life to me again. Family, community, getting about, driving my car, leading an ordinary life. For it to have been dealt with so professionally, so quickly, was absolutely marvellous.
We have actually already got a question in there, and can it be used if cancer has metastasized?
So that's a good question. The answer is that the recommendations that we have at the moment are for kidney cancer that is just within the kidney, but we use this technique for lots and lots of other types of treatment too. And so if, for example, you had a kidney cancer and that was all under control, and a metastatic lesion popped up somewhere else in the body, then yes, we could consider cryoablation. But really, it's for at the moment what's termed oligometastatic disease. In other words, only one or two lesions. So if you have really disseminated, widespread disease, it would not be appropriate. But we can use it for treating a bone lesion or a soft tissue lesion or even a lung lesion if it's just one and the primary tumour is under control.
Thank you. I've got another question. I'm going in for a biopsy on Thursday to hopefully go on to have it at Broomfield Hospital. Any advice would be appreciated.
I think the biopsy is a really good idea. So we would advocate that most people have a biopsy before having this done, partly because some of these small kidney tumours won't be a cancer; they'll be benign, so they won't be a cancer. So it's important to know that before you agree to having it treated. And sometimes we do the biopsy and we don't know what the answer is. So if we do the biopsy at the same time as the freezing, and then we don't get an answer, we'll never find out whether it was a cancer or not because it would have been treated. So my advice would be to go for the biopsy. The biopsy gives you an idea of what the procedure is like because it's the same sort of thing with a needle targeting the tumour. But I'm not sure how they do it at Broomfield, whether they do the ablation with a general anaesthetic or not. But most patients will say that the biopsy gives them some good experience of what will be coming. And it sounds a very sensible thing to get the biopsy done first.
Okay. So can I just ask then, so you're saying you don't know whether it'll be under GA. Would some places do cryoablation?
There are some very, very few centres in the UK that would do it without a general anaesthetic, so with sedation, but predominantly they would be treating smaller tumours that are appropriate for that. I say we've always used a general anaesthetic for everybody, and I think most centres in the UK do that too. But there are occasionally places that will offer it under sedation as a day case.
Okay, thank you. Just got another question. I had cryoablation 3 years ago successfully. A year ago, a possible mark was seen in a CT scan, and a year later, it was still the same size. So the interventionist radiologist reckoned that it was a cancer, it would have grown. Conclusion, it was probably not a cancer, so another CT scan each year to see.
I think that sounds very sensible. So even with kidney cancers that haven't been treated at all, that we're looking at as a surveillance protocol, we'd only expect them to grow by 3 or 4 millimeters every year. So they usually are very, very slow growing. So if you've had it treated and there's a small mark that they're suspicious of, I'd imagine that that's going to be a very small volume of tissue, potentially a centimetre or less. So if it's not particularly changing, it sounds very reasonable just to watch it at the moment. If you put that in the context of someone who hadn't had any treatment and had a 1 centimetre tumour, we would almost certainly suggest that it was watched rather than actively treated. So I think that sounds sensible. And it sounds as though if it did come to the point of needing further treatment, you're already linked in with a centre that could ablate it again for you, should that be needed.
And they've just added that it was 9mm.
Okay, so I wasn't far off with 10mm. I think that sounds very reasonable. If you wanted it retreated, I suspect they would offer that to you, but keeping an eye on it at this point would seem a very reasonable thing to do.
Yeah. So if somebody had had cryoablation and they were to have any regrowth, would cryoablation be another option for that new growth?
Absolutely. So once you've had if we use the sort of surgical terms, if you've had a partial nephrectomy, so if you've had an operation to remove your tumor, it becomes very, very difficult to do another operation. If you've had it frozen, it really makes no difference for us to do another procedure. So some patients who have, say, a condition where they make lots and lots of renal tumors, actually ablation is a brilliant thing because we can just keep treating and treating and it doesn't really affect us. So yes, quite commonly, if people need a second treatment, it will be with ablation again. And if people have had surgery and the tumor comes back at the site of surgery, they'll quite often come for ablation because it's easier to do than trying to do another operation.
And I was just going to ask, is it right that it's a double freeze, so it gets frozen once, thaws, and then you freeze again?
Yeah, you're absolutely right. So unfortunately, didn't quite get the gist of that in the video, but yes, we freeze the tumor for about 10 minutes, and that allows the ice within the water within the cancer cells to freeze and expand, and that ruptures the cells. And then we allow the thing to thaw for a few minutes, just to sort of turn into a bit of a slush. And then we freeze again, and that gets really confluent cell death, but it also means that the small blood vessels supplying the tumor get killed off, just like you'd see in something like frostbite. So yes, it's a double freeze. So the freezing itself takes about half an hour, but placing the probes can be a bit longer.
Thank you. We've just got another question. My partner is 35 with metastatic stage 4 RCC, sarcomatoid and rhabdoid features. He had a nephrectomy and 8cm tumor removed. The cancer progressed within 3 months of starting immunotherapy. He is now on cabo. If it works by shrinking the cancer in the lungs and lymph nodes, but not the tumor that's returned to the kidney site, could this be used then? And would this be covered under NHS funding?
That's a very complex case. As I say, the NICE guidance really relates to small primary tumours that haven't spread. The honest answer is that it would depend very much on how his treatment went and how much disease was there to be treated. As I said earlier, we can use cryoablation in a metastatic setting for 1 or possibly 2 lesions. If it's more widespread, then systemic anti-cancer therapy, so the cabo or other options would be the mainstay of treatment. So I'm sorry I sound a little bit political about that, but without sort of knowing what's going to happen and seeing scans and things, it's difficult to give an opinion. I suspect, and it would have to be MDT driven, so the multidisciplinary team, the oncologists and the surgeons would have to feel that it was an appropriate thing to do. So it's not a standard way of treating metastatic cancer, but in some very limited cases, it can have a role.
Thank you. Somebody's just put, thank you, you've just answered my question. This is a new 1cm lesion on my remaining kidney after a radical nephrectomy 4 years ago. Not sure. And they have said to wait and see.
Yeah, I don't think that's unreasonable. As I said, I think tumours at that size grow very slowly and can take a very long time before they would become, clinically relevant. There is a move, certainly where I work, patients that need treatment when they've only got 1 kidney, we would usually favour ablation rather than surgery, partly because it's easier, partly because the effect on the kidney function is less, so you preserve more kidney function by having ablation rather than surgery. And the risks of complications are slightly lower. Now, clearly, if you've got one kidney and there's a complication, you don't want to lose that kidney. And with ablation, we know that the complication rates are lower. And usually the way of getting yourself out of trouble if you're having ablation is to stop the bleeding by plugging off the small bleeding vessel. Unfortunately, if you're having an operation and there's lots of bleeding, often they have to do something much more drastic and potentially remove the kidney. So we have a better way of preserving the kidney with ablation than with surgery.
Yeah. Got another question here that says radiologist thought that if a further treatment was needed, then he may opt for radiofrequency ablation. Why would radio be chosen instead of cryo?
Yeah, so radiofrequency ablation is a heat-based ablation. So you place a probe, not similar to the way that I've described, and then at the end of it, it heats rather than it freezes. Now, some centres will have just one type of ablation, so just ice or just heat. Others will have more than that. Some people have a philosophy that if the treatment or if the tumour or part of the tumour has been resistant to, say, freezing, then try and hit it with the other one, try and heat it instead. Or vice versa, if you've had a heat-based treatment and a little bit has recurred, treat it with a different modality. I have to say my practice is just to keep using cryo because I know that I can see what I'm doing with the ice being visible under CT. And with heat, you can't quite see where it's being deposited so well. That being said, my choice is my choice because I know it works well. And all of these things are very operator dependent. So if the person that's advising and treating thinks that switching to radiofrequency ablation is appropriate at that point in time, then that is also probably reasonable.
Thank you. I've got another question here saying my tumour is 6 centimetres hanging off the bottom of my left kidney. I think they're asking if it would be cryoablation would be possible. And they're saying they've also got stable Mets.
Okay, so there are two parts to that answer. Should we be cryoablating a tumour of 6 centimetres? That would be above where we know we get the best results, which is the tumours of less than 4 centimetres. In some cases, it can be felt appropriate to treat tumours that are larger than that, acknowledging that the success rates or absolute cure rates might not be as good as having it surgically removed. So that's the first part of the question. The second part of the question is, should we treat the tumour in the setting of well-controlled metastatic disease? And again, I don't want to sound too much like a politician, but that really is an MDT-based decision. Whether the local team looking after the patient feel that treating the primary tumour would be appropriate. There's some debate as to whether, in the setting of metastatic disease, removing the kidney tumour is beneficial or not. So it would be unfair of me to give an opinion based on that information.
Thank you. I've just got another comment just saying that it was the hospital who wanted to move to cryo to radio because the cryo was found to be expensive. So
yeah, that's an interesting comment. So there are costs associated with all of these things. Inevitably, they are cheaper than having surgery. So that's the first thing that doctors always want to say to the managers. It's cheaper than having an operation. The other thing is that the needles that we use are currently paid for by NHS England or the Central Health Trust and not by the local hospital. But I would expect it's true that if you were to use a radiofrequency probe, it might be cheaper than the cryoablation probe. It's a local assessment, and it depends on the local factors in the trust.
Thank you. had a couple of comments in the chat as well, just saying thank you. And somebody's put thank you. That's put your answer, put their mind at rest.
Good.
So really appreciate that. I'll just give a couple more minutes. If anybody else wants any of the questions answered, if anything else comes to mind. So I'll just give you a bit of typing time if there is anything from anyone else. But I found it very interesting. I didn't realize that there would be like that bit of frost on the outside. I was like, oh.
At the center of the ice ball, it's like minus 140 degrees Celsius.
Wow.
So it's incredibly cold. So all of the tubes that the gas passes through gets cold too. So we get a little frost party on the top of the pros.
Somebody's just said this session was very useful. Thank you. And about doing some more sessions. So brilliant. Yeah. Glad that it was useful.
Yes.
And like I say, if anybody else has got any questions, we'll just give it that extra minute, because some of them have been quite complex. So just in case anybody's typing at the moment, we'll just give a little bit more time.
The important thing for me to say is that whilst this is very well established in my hospital, it's new to a lot of other places, and it's not available in every centre, unfortunately. But we, as patients, we're allowed to go to our doctors and say, please, could you find me somewhere where I could have this treatment? So do talk about it, raise awareness, and make sure people know that they can ask.
Yeah, that's a very good point. Very good point about just because it's not available at your centre. If it's something that is suitable for you, you can ask to go somewhere else to have treatment. But yeah, that's a really good point. So we just got another question come in saying, I am 12 weeks post-ablation for a 4.3 centimetre tumour. So far, feel really well and so much better. Do you find patients generally report feeling much better?
The honest answer is that most of the patients don't even know they've got a tumour and get very little symptoms from having the tumour originally. But it would absolutely make sense that if you've had some symptoms or malaise or whatever related to the tumour that you've had, that once it's been treated, that should improve. As I said earlier, we tend to tell patients that some of them will feel fine and not really have any discomfort and go home the same day. Others with perhaps slightly larger tumours of 4 centimetres will take 2 or 3 days to recover. But the recovery should be measured in days rather than weeks, which is different to surgery, which would be weeks to months. So yes, I'm delighted that you're feeling better and that it's all going well. And hopefully the next scan will show that it's all been treated successfully.
Yeah. Someone's just asked, once you've had treatment, when will you get a follow-up, and how often after that will I be checked?
Yeah, that's a good question. And I should have talked about that earlier. So it slightly varies depending on who's treating you and where you're being treated. But the general rule of thumb that we have is that you would have a scan a month after your treatment to really assess whether the treatment's been completely successful. And to check that there isn't a sign of any ongoing complication. Now, if that scan at 1 month looks absolutely fine in our centre, we would then not scan you probably for a year. Because like I said earlier, even if you had a tumour that we were watching, we wouldn't expect it to grow more than 3 or 4 millimetres per year. So we have to wait long enough to check that the treatment's been sustained and successful. So we would normally scan at a month, and then at a year, and then sometimes at 3 years and 5 years after treatment. I think there's a trend, perhaps more across the country, to scan almost every year. And even in that first year after treatment, some people will get a more frequent scan at, say, 3 months and 6 months as well. But generally, it's one follow-up scan in fairly short order after the ablation to make sure it's been successful and you don't need to repeat it or deal with a complication. And then routine follow-up, which really, as time goes on, could be annually.
Thank you. We've just had another comment of somebody saying, thank you so much for the info.
My pleasure.
Brilliant. Oh, one more. My radiologist said it would feel as though I have been kicked in the back by a horse. However, I recovered the next day and it felt more like a small pony or a large dog.
So,
So tell others it doesn't really hurt.
yeah, no, it's always very difficult. Patients ask me, is this going to hurt? And I can honestly say that patients like David, who was in the video at the end, had no sort of knowledge that anything had been done. And about half of the patients we treat, we go and see afterwards, and they say, genuinely, unless I had that big plaster on, I wouldn't know that you'd done anything. And others, I tend to, rather than sort of kicked by a horse, I tend to say, I feel like you've banged yourself on the kitchen table or something, when you just knocked yourself and it doesn't quite feel right for a day. That's really what we should expect. This isn't a procedure that people should have to convalesce afterwards, up and about the same evening, walking around the ward, home the next day, back to normal duties, back to work within a few days, if that's what you feel up to. So yeah, it should be a sort of minor interruption to people's normal life.
Okay. So I'll just give 1 more minute just in case anybody is typing. But no, it's been very informative. I've found it very interesting seeing the pictures, but even though knowing about it, I don't think I've really seen it in such detail with them going into the scanner, you putting the probes in and everything. It's very interesting. But yeah, so I think we'll leave it there then. If there is anything that anybody wants to follow up with after, they can always contact us at Kidney Cancer UK. You can either call the support line, which is in my little box, and that's 0800 002 9002, or we do have our email, which is support@caseuk.org.uk. Okay, but I think we'll bring the webinar to a close there. But thank you very much for everyone for joining. And like I say, if there's anything that anybody's got any questions about afterwards, please do get in touch. Thank you.